Malaysia. We are now in the month of infectious disease, and the topic for today is approach to Candidemia, when to suspect and how to treat. Speaker for today is Dr. Nadia Hanim, ID physician from Hospital Sungai Petani, and the chairperson for today is Dr. Lau Li Li, infectious disease consultant from Hospital Sultan Bahia, Alostar. Dr. Lau Li actually obtained her medical degree from University Kebangsaan Malaysia in the year of 2000 and completed her MRCP UK in the year of 2006. She is an infectious disease physician since 2011. She is the head of infectious disease for the state of Kedah, as well chief coordinator of infection control and AMS committee for the Kedah state. She involved in making guidelines for HIV, antiretroviral treatment, national antimicrobial guidelines, and COVID-19 guidelines. She also has published various publications till date. Without further ado, let's welcome Dr. Lau Li Li.
Thank you, Dr. Priscilla. Thanks for the introductions. So I think our focus today will be on the topic of Candidemia, the approach and how to manage. So we have our speaker here, Dr. Nadia Hanim. She's an infectious disease physician from Hospital Sultan Abdul Halim Sungai Petani. She was my colleague and my comrade not too long ago. We were working together in Bahia. She was my the right-hand person during the COVID-19 pandemic. So right now she's working with Hospital Sultan Abdul Halim. So she ventured to a greener pathway in still with government, but it's a different hospital. So she's a young ID physician by experience. I think she's most appropriate right now to address today on Candidemia. So I'll pass the mic over to you, Dr. Nadia.
So thank you, Dr. Lily, for the warm welcome. So first of all, I would like to thank the College of Physicians Malaysia for inviting me to be part of this infectious disease month for medical webinar. So my topic today is actually approach to Candidemia, and as this webinar is aimed for junior MOs and junior physicians, I'll try to make it relevant to our usual clinical daily practice. Okay, so at the end of the session, I hope that we know when should we be suspecting Candidemia and how do we treat them. Okay, first of all, I would like to welcome all to the world of fungus. And as you can see, it is very colorful. But basically from this picture, it can mainly be divided into these two groups. So on your left is your yeast, very colorful, but it can also cause that very bad oral candidiasis, but it's so useful in our daily life when we eat our breads daily. And on your right would be the mole. So you have got yeast and mole. And mold is when your bread get moldy, so that is when our mold is acting lah. And it can also cause serious disease, as in the picture is on penicillosis. So today our topic Candida is under the group of yeast, so I'll be focusing on Candida. Okay. So basically Candida is very common, and there are so many of them. So in total there are more than 200 species, and luckily for us, not all are pathogenic lah. So these are the major pathogens which account for more than 90% of infection. So we got Candida albicans, Candida parapsilosis, Grabata, tropicalis, and cruzi. And the predominant strain or the soil has been albicans. However, as you can see later on, non-albican species are actually increasingly common. So we got a bit of local data. So this is a review of studies on Candida species in Peninsular Malaysia. So this was actually just published last year. So this author compiled data from 22 studies, which were published from the year 2009 and 2018. And you can see our common Candida species is the same as the general the world population. Candida predominantly is the most common organism, followed by Glabrata, parapsilosis, tropicalis, and cruzi. And this is Dr. Lily's study led by Dr. Yao. So it was actually that when they studied in a more recent samples, I would say. So it was from the year 2016 until to the year of 2020, where still predominant organism is our albicans, followed by but you can see the change as compared to our previous national data. Paraxyllosis tropicalis, glabata. Okay. Okay, but something. So when I look into this study, so this thing caught my eyes lah. So the name is a bit odd, Nacasiomyces glabrata. So it's just that I am taking this chance to actually to alert everybody regarding some changes in recent changes in the taxonomy, in the name in the taxonomy of the fungus. So if you were made aware, so recently, maybe in end of last year, early this year, there has been a few changes. Actually, I would say major changes in the taxonomy in our fungus. In our fungus. So this is because they adopt the molecular approach to the fungal identification. So therefore, by doing molecular approach, they have found that the correct taxonomic relationship and affiliations is now recognized. So we are now, because of the molecular changes, so we are now changing the names based on the characteristics. So if you are interested, you can read these articles by Sarah Kidd. So this article actually explains why was there the changes for the fungal taxonomy lah. Okay, so just to update some changes. So luckily, some remain the same. Albicans, Paraxyllosis tropicalis, and oris still maintain the same name, but even our usual Candida, for example, Candida glabrata is now Nacasiomyces glabrata. Cruzai is now called Pichia cutria zevi. Guillemandi is now Meierozima guillemandi. Lusitani is now Clavispora lusitani. So I would say this would be rather confusing, not only for the general population, but also for the ID physician. But luckily, I think most labs, including our labs, hopefully they do adopt this practice of putting the new names and also highlighting the old names. So for example, they put the new name Nacasiomyces glabrata, and in bracket they put as formerly known as something. Okay, so that we do not get confused. Okay. So now I go straight to Candida infection. So basically, how do we get Candida infection? So as you know, Candida is a normal flora. There are lots of Candida in our GI tract and also in our skin. So when there is any imbalance, they can actually invade and cause infection to our body. So the most common would be so from the GI source, how does it invade to our body is actually through translocation or anastomotic leakage. Okay, so number one, if a person is exposed to antibiotic, it then kills off your normal flora. So when this happens, there will be a bit of changes in the microbiome. So it causes overgrowth of the yeast. So this will then the yeast then can be translocated and causes systemic dissemination. And somebody who has got some mucosal damage, for example, those who had post-chemo mucositis, those who had GI surgery are also at risk of getting Candidemia. Okay, then the next common source would be from the skin source. Okay, so if there is any breach in the skin integrity, so it can predispose a patient to have invasive Candidemia, because central venous catheter-related Candidemia is associated with higher organism burden compared to extravascular source. Okay, so and if there is any indwelling catheter, it then can cause biofilm and subsequently causes persistent Candidemia. Okay, so basically, invasive candidiasis is not only concerning Candidemia. So you can see there are actually in these circles, there are actually a spectrum on 3 clinical spectrum on how a patient can present with invasive candidiasis. Number one would be a person who has got Candidemia but without any deep-seated candidiasis. Someone who has got, number two would be someone who has got Candidemia and also deep-seated candidiasis. Number three would be deep-seated candidiasis without any Candidemia. Okay, So basically, clinically, to make it easy, someone who has got disseminated disease can present with candidemia, hepatosplenic candidiasis, and also acute disseminated candidiasis, or it can cause a deep-seated candidiasis, or we call it as focal infection, where it can only involve the urinary tract, and involve the eye, causing endophthalmitis, involve the bones, causing osteoarticular infection, involve the heart, causing endocarditis, involve the intra-ab, causing peritonitis and intra-abdominal infection. Okay, so for example, this deep-seated, in terms of deep-seated infection, they may actually remain localized or lead to secondary candidemia. So, for example, during candidemia, fungus in the bloodstream can enter the urine, so it then causes candiduria, so urine in the candida. So so someone with candida can also cause can have got deep-seated candidiasis, can cause ascending pyelonephritis, and this can cause secondary candidemia. So it's a vice versa thing lah. This deep-seated candidiasis can cause candidemia, or candidemia can cause disseminated disease. Okay. So a bit on disseminated candidiasis. So when someone has got candidemia, it then causes hematogenous spread to other organs. So, for example, the eye, kidney, heart, brain. And how do they present? Would be they can present with minimal fever to a full-blown sepsis syndrome, which is not cannot be difficult to be differentiated from your severe bacterial infection. And in the previous studies, they have found that only 15 to 40% are diagnosed early of this candidiasis. So how do we actually diagnose? We must be alert on the clinical clues. For example, if someone presented with endophthalmitis or eye involvement, so part is part of your Candida endophthalmitis. So an old study somewhere in 1994, they showed that there are about 100 patients of candidemia. When they do ophthalmic examination within 7 hours, the presence of chororetinitis is in about 9%. And the risk factor for this patient to develop eye involvement would be this patient do have Candida albicans, multiple blood cultures positive, immunosuppressed, and so has got visual symptoms. And this is something that we do clinically. When we ask for any skin changes or not. These are the skin changes when they can present with pustule lesion in erythematous base, as you can see in your on the left picture, or the more common, the more striking would be this central necrosis with this nodular lesion with central necrosis with that underlying erythematous base. Okay, so this is what we call as fungal spots more commonly known as fungal spots. Okay. Another presentation for disseminated would be hepatosplenic candidiasis. When this is common in our clinical practice, someone with persistent fever, usually high spiking temperature, and it has been found more commonly in those in hematological patients who were previously neutropenic. And once the neutropenic counts has returned to normal, this is what happened. Because anyhow, for someone to manifest infection, you need to have that cellular immunity reaction. So how do they present would be the usual thing right hypogonadal pain, vomiting, anorexia, and ALP rates, you should be thinking of abscess. And when you do imaging, so these are the features, micro abscesses in the liver, spleens, and kidneys. Okay, so basically, to summarize the pathogenesis of Candida infection, it first start off with Candida colonizing our GIT, our skin, our genitourinary system, and there is imbalance between the host factors where they become at risk of infection, and there is breach in the barrier defense, and also some external causes, for example, antibiotic use and also exposure. So these all, any imbalance between all these causes infection, which then can be spread into bloodstream or localized into sterile cavity. Okay. So as you can see, when it goes into bloodstream, it becomes candidemia and then causes hematogenous distension into the organs. Or if it happens in sterile cavity, it can cause localized deep-seated infection, which can subsequently might also lead to candidemia. Okay. Okay. So now we have gone past a bit on the pathogenesis theory parts on Candida. So this is when you see a patient, how do you actually approach? If you get candidemia, I would say that would be rather easy. But our thing is our our aim is really for us to diagnose probable candidiasis before for us to diagnose candidemia, not when culture already came back. So number one, you need to know, is the patient at high probability of having candidemia or not? So what are the things that we look for would be, what are the risk factors of the patient, any sign and symptoms of the patient, whether the patient has got fever, or this abdominal pain and all. And subsequently, we do have risk scoring to actually to make it easier for us to establish the probability of those patients of having candidemia. Okay, so the first thing is that multiple studies has actually identified the risk factors for invasive candidiasis. So these are invasive candidiasis. These are the patients in ICUs. So namely, there are critical illness, especially long ICU stay, those who had abdominal surgery, especially those who had anastomotic leakage or repeated laparotomies, necrotizing pancreatitis, or this hematological malignancy, transplants, use of broad-spectrum antibiotic, presence of central venous catheter, TPN, hemodialysis, Candida colonization. So the thing is, so as you can see, it's actually quite common in almost all ICU patients. So what it actually means is that there is imbalance. So for example, there is a barrier destruction because of the catheter, post-chemo, they have got mucositis, antibiotic exposure causing the change in the microbiomes, and also the cell immunity in those with neutropenic and transplant. But this I would say this would be rather vague. Therefore, they have come with risk scoring. So this scoring is, there are previous studies has come up with all this risk scoring to help us to identify which of those patients who get all those risk factors are actually at a higher risk of getting candidiasis. So there has been multiple scoring that has been published. For example, those they have looked for usage of TPM, antibiotic, colonization, colonization sites and all. Okay, but the thing is, these risk factors, they have got high high NPV, but unfortunately they have got a bit on the lower positive predictive value. So I'll go into two more commonly known risk scoring lah. So number one would be, so as you can see, they have got high NPV, but unfortunately they have got lower PPV lah. Okay, so first scoring would be on Candida colonization index, where they look at sites that the non-sterile site which is being colonized by Candida. Okay, a bit on Candida colonization, so meaning that it is Candida which is being isolated from non-sterile site, which are, one would be from your swab, from your tracheal secretion, from your stomach, rectal, urine and all. So, but there is no evidence of infection. So, so previous studies has suggested that colonization with Candida is an independent predictor of candidemia, where they say that candidemia is very uncommon in a patient who is not colonized by Candida. Okay, so it makes sense. But the thing is, anybody, if you were to screen anybody in the ICU, by the time they enter ICU, 5 to 15% of those patients are already colonized by Candida. But subsequent studies shows that this proven colonization assessment alone is no longer a good predictive tool. So because 80% of colonization rate in ICU, out of this 80%, only 10% do develop infection. So prior to this, they were using this colonization index to give prophylaxis treatment. So based on this study, it shows that by just looking at colonization index, it's not it shows no mortality benefits for prophylaxis therapy, and it causes more harm by increasing the risk of resistance and also change in the fungal ecology in the ICU. Another famous score would be Candida score, where they have got this TPN, sepsis, abdominal surgery, and multiple Candida colonization. Same thing, good NPV, but the issues with this is the low PPV. And as you can see, if the score is higher, for example, score, can you at the left side, if the score is less than 3, instead is only 2.3. But if the cutoff point is more than 3, you can see it goes up to more than to 16.8. Okay, but issues with this is very common in ICU patient to have all the risk factors. So what has been done to improve? So this is a study by this is what has been done by the Australian people, where they try to increase the yield of the scoring by doing some alteration to the risk scoring by doing corrected colonization. So what does it mean by when they do this corrected colonization? The PPV from 5.3 actually it goes up to 23.8, meaning that by changing some of the parameters, they actually increase the yield. Okay, so what it means is that they look at the amount, the density of the colonization is much more to be part of the scoring. Okay, so now that we have already identified who are those patients who are at risk, high probability of getting Candidemia, next thing will be in terms of workout lah. So number one rule would be you need to take high volume blood culture prior to initiating any treatment, because this is going to help us to manage the patient. Okay, basically culture is the gold standard. However, there is still a limitation because only about 50% of blood culture is positive, and it is much more less in patients with prior antifungal and with those who are non-albicans. And another downside would be they have got slow turnaround time, meaning that for you to have any signals, you need at least 2-3 days, and in some organisms it needs more than 7 days, which is for glabrata. And if it is from deep-seated sites, the sensitivity is even lower, and sometimes it is difficult to get samples from the deep-seated sites. Okay, so culture is the gold standard, but the yield is still not satisfactory lah. Okay, so this article actually try to discuss lah how to find the missing 50%. So basically they do suggest non-culture diagnostic. Non-culture diagnostic to actually help us in finding in getting the gaps of this undiagnosed. Okay, so next will be first will be culture. The next workup will be non-culture based workup. Okay, so basically non-culture based workup, the good thing is that it has got shorter time to positivity compared to standard cultures. Good sensitivity and specificity, but it doesn't replace culture because we do not have any information on your susceptibility to the antifungals. Basically, it can be divided into two. You have got molecular or PCR available, but it is only in central labs, and fungal biomarkers. So they are getting more and more recognition, and I think we do not have much. So example would be beta-glucan, menin, and so Candida albicans germ tubes antibody. So first I'll go into beta-glucan. I think it's available in, but it's only available in some center. And what is beta-glucan? It's actually a component of the fungal cell wall. It's a pan-fungal marker, meaning that it can identify almost all fungus except for Cryptococcal, mucorales, and blastomides. It has got excellent negative predictive value, but the sensitivity specificity is variable, as you can see down there. And because of the excellent negative predictive value, the use is actually more into, you can use more into antimicrobial, so meaning that you start your anti-fungal empirically, and if it's negative, then it's time to stop your antifungal. You can see the negative predictive value is up to 99 to 100%. Okay, but thing with beta-glucan is that it has got false positive. So someone who has been exposed to human blood product, for example, albumin, immunoglobulin, hemodialysis, gauze, antibiotics, and all. These are some of the things that can cause false positive result. Okay. Okay. Next test will be menin and anti-menin. So menin is a major component of albicans cell wall, and so it is one of the main Candida albicans that circulate during infection, and it has got good performance with albicans, glabrata, and tropicalis. And the good thing about it is that this test can yield positivity earlier before your culture, meaning that 7 days before the culture result turn out to be positive, or even up to 16 days before any radiological evidence of invasive candidiasis. So basically, the positivity is much faster lah, as compared to the other things. Another test would be Candida albicans germ-2 antibody. So it's an immunofluorescence test for the detection of anti-mycelium antibodies against several Candida species. So it detects response against hyphal protein expressed during tissue invasion and biofilm formation. Sensitivity about variable 42 to 96%, specificity 54 to 100%. But the good thing about this germ-tube antibody is that if it's positive, it is suggestive of deep-seated infection, deep-seated candidiasis, okay, and it is less sensitive in tropicalis. And another final test I have to share here would be T2 Candida panel. So it's a combination of PCR technology with nanoparticle-based hybridization, can detect pathogen even with a low fungal load, 1 to 3 CFU per ml, good sensitivity, high NPV, and is able to detect albicans, tropicalis, parapsilosis, Grabata cruzi. So it was meant to detect all these things, but with time, now it's able to detect Auris, Hemorrhoida, and Lusitania. So, and a very fast turnaround time of only 5 hours. Okay. And something that we do have PCR, but it's only available in Anti-Central Lab. So it's targeted lah. So it targets specific Candida species, albicans, tropicalis, parapsilosis, Grabata cruzi, and has got good sensitivity and specificity lah. And if you give a sample of whole blood, it's much better than serum. And if we do Candida specific, it's much better compared to multiplex assay. So basically, as a summary, you've got sensitivity to diagnose invasive candidiasis. PCR is better. PCR BG is much better than your culture, especially in deep-seated candidiasis. However, as you know, it's not readily available, and I think we only have got access to, and which is also not readily available, to PCR and also glucan. Okay. Now, now we already look up who are at high probability of getting candidiasis. Then we have sent whatever workup that we can send. Now, what is the management lah? So basically, these are the main principles lah. So number one would be early adequate antifungal therapy. So we try within as much as 72 hours from your culture. Early source control, follow up blood culture, ophthalmic examination, echo, and so adequate duration of therapy. So out of these principles, the most important, all these are important, but the one in red, the adequate antifungal therapy, early source control, and adequate duration of therapy has been found to be statistically proven in terms of in reducing the mortality and effectiveness of the treatment. Okay, number one, we go into antifungal therapy. So basically, in antifungal treatment approach, you've got this few approach lah. You've got prophylactic approach, empirical, preemptive, and targeted. So in prophylaxis therapy, it is, if you are in, we are not discussing today, but if you are in hemato, so maybe you can see patients who are already on antifungal prophylaxis. So they are asymptomatic, but they are high-risk patients. For example, those with prolonged neutropenic hematomation, and they are started on prophylactic antifungal treatment. Empirical would be those who are ill, febrile, not responding therapy. So we take all the culture, image, and all, then we start patient on empirical treatment. Preemptive is when we got diagnostic driven. For example, patients who are symptomatic high risk, then we send your biomarkers. Then we start treatment. You start treatment while waiting for the result of fungal biomarkers. And targeted is when you have got all the results. Okay. In terms of prophylaxis, this is prophylaxis therapy for ICU use lah. So IDSA actually give a weak recommendation lah of giving Fluconazole or Echinocandin, but these are very weak recommendation. And subsequently, this was somewhere in 2016, but more recent recommendation, which is by the SMIT committee, they actually recommending against routine and universal administration of antifungal prophylaxis in critical ill patients. So basically, we are not recommending prophylactic antifungal use. Okay, then we go into empirical approach. So IDSA is actually suggesting empirical therapy for those who are critically ill with risk factors for invasive candidiasis, the risk factor that I mentioned before, and having who are also in shock, no other cause of fever, and has got clinical assessment of risk factors, surrogate markers for invasive candidiasis, or this is your colonization, culture data from non-sterile sites. So if they do have all these criteria, they do recommend for empirical therapy. And Aspin also suggests for empirical antifungal therapy for those who are in septic shock with multi-organ failure and also have got more than one extra digestive site of Candida colonization. Okay. And basically, how long do we give empirical therapy? So IDSA suggests that you give empirical therapy for 4 to 5 days. If there is no clinical response and subsequently no evidence of invasive candidiasis, they would suggest to stopping the antifungal therapy. Okay, so that was on antifungal therapy. So the next principle would be source control. So basically, if we can do this, we try to remove CBC your catheters, and basically, what is the rationale between removing your catheters? Because number one, it can become your, as I mentioned just now, it can become your primary Candidemia source, and as with other catheters, it can causes causes biofilm, and this biofilm can cause persistent foci, and subsequently, if you were to do if you were to test, they have got relative higher drug resistance within the biofilm. Okay, and studies, multiple studies has shown that by taking off all these catheters and also adequate treatment, it causes significant decrease in all-cause mortality. Okay. Number two would be in terms of source control. If there is any abscess, as long as they are drainable, we try to drain the abscess. Okay. This is not in terms of Candidemia, but if let's say patient with CBD, they do have asymptomatic Candiduria. So it is rather a common findings. So it can be up to 20% admitted to ICU. And you know that by removing the CBD, majority of funguria is actually resolved after the removal of the CBD. Okay. Okay. So you already started your antifungal. You already done your source control. So what are the things that you need to do? So you need to repeat your blood culture, and subsequently whether you can proceed with automatic examination and so imaging. So when do we do follow-up blood culture? So we usually wait until day 3 for a repeat blood culture, and we should routinely perform ophthalmic examination to look for presence of endophthalmitis. And if a patient who is critically immunocompromised, we should do a routine imaging to look for hepatosplenic abscess. Okay? And finally, we come to adequate duration of therapy. So once so number one, you repeat your blood culture at day 3. So if it is still positive, you need to repeat until you get a negative culture, and treatment would be at least 14 days after the first negative blood culture. Okay, so I'll be touching a bit on antifungal, which one, the one which is in relation to our clinical practice. So basically, this diagram actually summarize the common the candidas and which antifungal that it is susceptible to. So in our practice, we got azoles and we more commonly much readily available with Fluconazole, and we got Echinocandins and so M4B. So you can refer to this to look for which antifungal that the Candida is likely to be susceptible to. And okay, so a bit on Candida and resistance lah. So albicans, they are rarely resistant lah, except those with long-term antifungal use in compromised hosts. Okay, in terms of cruzi, we know that they are Fluconazole resistant. Glabrata, up to 25% are azole resistant, and in some they are also Echinocandin resistant. And paraxyllosis, they are Echinocandins resistant. And you got the more virulent species, less common species, for example, Oris, Gulimandi, rugosa. They have got intrinsic resistance to azole and Echinocandins. Okay, so this is quite an interesting study lah. So it shows what exposure to prior antifungal causes to the subsequent epidemiology of the Candidemia lah. So it involved up to 2,000 patients, and they were given either Fluco or Caspofungin. So for those who for after being exposed to Fluconazole, they see that the epidemiology of Candidemia shows that there is reduced prevalence of Candida albicans, and so Candida albicans become less common, and less drug susceptible species become more common. Okay, Gravata, cruzi become more common, and if they are exposed to Caspofungin, so you are increased prevalence of your parapsilosis. As I mentioned just now, it has got resistance to your Echinocandins, and also to the more resistant organism, which are Gravata and cruzi. So it shows that exposure to antifungal can cause marked shift in the epidemiology of your Candida. Okay. So basically, you come to so in large, you got two options lah, whether you want to start Fluconazole or Echinocandins. So basically, Fluconazole is the preferred antifungal. So the usual dose would be 800. Then you load with 800 mg. Then 400 mg OD. So this is just a guide, but weight-wise is 12 mg per kg, followed by 6 mg per kg. And when should you be considering to start patient on Echinocandin? When, number one, if they are clinically unstable, or you suspect patient has got azole-resistant Candida. So who are those who are at risk of getting azole-resistant Candida? As I showed with the previous study, those who had prior azole exposure, or if the patient has got previously were colonized by Candida, which are azole resistant, which is Gravata and cruzi, or patient with liver impairment, severe liver impairment, because you know that azole groups are associated with transaminitis. Okay. So the option that you got with Echinocandins will be Anidulafungin, you got Mecafungin, also Caspofungin. You can choose any of them. Okay. So IDSA also give similar recommendation. Echinocandin, they suggest you can recommend it as an initial. This is for ICU patient. So they suggest for initial therapy, and if patient is not critically ill, and not likely to have Fluconazole resistant Candida, they suggest Fluco, and you can also use M4B if patient is intolerance or any the Candida is resistance. Okay, so once you're already started on antifungal, you come to the question of de-escalation. So when should you de-escalate? So if you were to start patient on Echinocandins, you should de-escalate to Fluconazole when you get a culture positive which shows susceptibility to azole. So usually, as I mentioned in the blood culture, so you need at least 5 to 7 days for you to get a positive yield. And if patient was started on Fluconazole, so if patient is stable, the GI tract is functioning, so you can change your IV to oral because of the good bioavailability of the oral Fluconazole. Okay. So before I end, just to summarize, how do you approach for any suspected Candidemia? So basically, when should you suspect? When patient has got persistent sepsis fever despite antibiotic, critically ill, got risk factors, or got inotroches, for example. And what are the risk factors? One would be multifocal colonizations, got intra-app surgery, especially with enzymatic leak, recurrent GI perforation, TPM, exposure to broad-spectrum antibiotic. And so these are the people that we should be suspecting high risk, high probability of invasive candidiasis. Okay, so what we do is that we need to send, number one, we need, prior to initiating treatment, need to send sample first. So is either you got, if you have, number one, mandatory for us to send blood culture. And if you got access to fungal biomarkers, please do send. And if there is any infected tissue or other serous site, we can also send for samples. Okay. Then your choice of antifungal, you can start Echinocandins or Fluconazole. And after you start empirical antifungal, you need to review the patient clinical response, okay, at 3 to 5 days. So if it is negative, you should consider stopping your antifungal therapy and reconsider diagnosis and reassessment. But if it is positive, when you get isolation of Candida species from sterile site culture, so you do all the steps that I mentioned before, you try to source control, meaning that you remove a change line whenever feasible, need to repeat blood culture after 72 hours to look for clearance, and look for the susceptibility, and then depending whether need for eye examination or echocardiogram, and duration wise will be 14 days from your culture clearance. Okay, so I've come to my last slide. So my take home message that it is Candida infection is something becoming more and more common, especially for inpatient, ill patient, and also in the general wards. And prior to this, you know that albicans is the predominant species, but now we are seeing more and more of non-albicans species, and we are also seeing increasing fluconazole resistance. And we can start empirical treatment in high risk situation, but the use of antifungal must balance between number one is the cost, the risk of toxicity, and what is most important is the emergence of resistance. Okay, with that I end my presentation.
Thank you, Dr. Nadia. So it's not easy to summarize Candidemia in a 30 to 40 minutes talk. So Candidemia or invasive candidiasis is a big topic by itself. I think if we want to go into it, we need probably the whole day event to discuss on the great details. So Dr. Nadia has gone through the pathogenesis, the risk factors, signs, symptoms, the scoring system, and also the different modality of diagnosis and the different type of treatment, namely the prophylaxis, empirical, preemptive, and the targeted therapy. She also has gone through and discussed about the different antifungals treatment and also when to consider the different types of antifungal agents. So I can see there's still no questions. Maybe some still need time to warm up. If you have any questions, please feel free to type at the Q&A box at the panel below your screen. Now, maybe I just start off by asking one or two questions to Dr. Nadia. So among the Candida scoring system that you have mentioned, perhaps can you tell us which is the Candida scoring system that you think is more appropriate, or which risk factors that you think more sensitive to pick up patients that really at risk of Candida infections?
Okay, so thank you, Dr. Lily, for the question. So I think from the many scoring that I've shared before, so I think the most I think the best not best lah, the one that we use in clinical practice would be the Candida scoring lah. So where the risk factor would be use of TPN in the intra-abdominal surgery, anastomotic, or the other risk factor would be anastomotic leak, and multiple Candida colonization would be the main risk factors lah.
Okay. As a whole, Dr. Nadia is trying to summarize that Candida is a colonizer on our skin and also our GI tract. Therefore, in the talk, if you notice, we already mentioned when there is any breach of the barrier, there is increased risk of invasive candidiasis, for example, the perforations of gut or anastomotic leak. So next, there's the questions are very relevant here. How can we differentiate the colonizations of Candida versus the true infections? Dr. Nadia, your view?
Okay. So whether this is colonizer or true infection, so number one would be so for something to be said a colonizer, it has to be from a non-sterile site, and basically we know that Candida is a colonizer in many parts of our body. So which is why we need all these multiple colonization, multiple sites of colonization for it to be a risk factors, because it is a normal flora in many sites of our body.
Yeah, it's indeed in the clinical practice, it's not easy always how to differentiate Candida as a colonization versus a true infections. I think as a clinicians, I think we remember that our senior doctors always teach us that we always have to correlate with the clinical conditions. So for the non-sterile side, we always have to correlate with the clinical features where to decide whether it's a true infection versus colonizations, especially from the non-sterile side. And while waiting for other questions to come in, if let's say there was a Candida species isolated from tracheoaspirate in a patient that ventilated in ICU, the tracheoaspirate was aspirated through the ET tube. Would you consider as significant as a true infections or colonizations?
Okay, so as I presented earlier on, so Candida colonization in ICU patient is very common. So I would say we should, based on that tracheoaspirate, it is common for us to find Candida colonization, and it shouldn't be treated as per infection.
Yeah, I believe that the reasons that we seldom treat tracheoaspirate Candida isolate as true infections because Candida causing pneumonia is very rare or rather uncommon. So the next questions, of course, will be if let's say one would to be isolate the Candida species from the urinary specimen, would you then consider that as infections or colonizations?
That is also very difficult to answer because most commonly it is a colonizer. Also, or we call it as Candiduria. So most commonly, if patient is on CBD, patient has got Candiduria, by just removing the CBD, you can actually remove the source. Okay, and it's actually might be a markers of systemic infection as compared to a local infection. So you must go back to your clinical presentation. So.
Yeah, there's another questions for you from our friend here, Dr. Leslie. Now the questions goes like this. Can you elaborate more on the skin lesions as clues for candidiasis or
Dr. Lily,
candidemia?
my line is
Are
breaking.
there any unique or special features that can differentiate from other infections? I'll read again. Can you elaborate more on the skin lesions as clues for candidiasis or candidemia? Are there any unique or special features?
Okay.
You can type on the Q&A. I think it was written there.
The line is a bit breaking, but I can read from the chat. So basically, if you the one that we see is that if there is a nodular lesion with a central necrosis, with the erythematous base, that would be your septic spot for fungal. That is one of the pathognomonic, not pathognomonic, the common presentation of skin lesion for Candidemia.
Yeah, perhaps if I'm allowed to chip in, the nodular lesions that associated with invasive candidiasis, the appearance usually is a nodule, sometimes purplish, with or without central necrosis. Of course, it may not be able to differentiate for others conditions, for example, ectaima gangrenosum caused by Pseudomonas aeruginosa. So, and other conditions, like for example, erythema nodosum. But as a whole, again, as a clinician, we always have to go back to the patient risk factor. If we know that this patient has got the risk factors for invasive candidiasis, and you see that these nodules are present on the body, we have to suspect invasive candidiasis. So there's no other questions on the chat box. So maybe last questions from me. So Dr. Nadia did discuss about the choice of antifungal therapy, especially as empirical antifungal therapy, Fluconazole versus Echinocandins. And we all know that Echinocandins, in terms of price, is not easily accessible in most of hospital except in the bigger hospital. So in that sense, where would you consider echinocandins versus fluconazole, and in the setting whereby echinocandin is not available, what would be your recommendations?
Okay. So as mentioned, fluconazole is our preferred antifungal agents, but as I mentioned before in my slides, when should we be considering for echinocandins would be one patient is clinically unstable, and and if you suspect a azole-resistant Candida, so meaning that patient was previously colonized by an azole-resistant Candida or has got any previous azole exposure, and also if patient has got very bad liver impairment. Okay, so these are the criteria that we would prefer to choose echinocandin as opposed to your fluconazole. And if echinocandin is not available, then I think our next choice might need to be M4B.
Yeah, I totally agree. So in a set, I think it's it also goes back to our antibiogram. I think it's very important to know your own hospital bugs. For example, in my hospital, I know that most of my Candida albicans, they remain sensitive to fluconazole. So in that scenario, if a patient that I do not suspect, patient has got azole resistance, Candidemia, i.e. patient has not been exposed to azole in the past 3 to 6 months, I think if in the constraints conditions, I think it's probably quite appropriate to use fluconazole. Unless that patient is critically ill, then perhaps you have to source out for echinocandins or even amphotericin B if, let's say, echinocandins is really not available at that point in time. So there's another question that just popped up. Can Candidemia be a contaminant? Meaning that when you do the blood cultures group Candida species, or should it always consider as infections and prompt immediate treatment?
So I think Candidemia would be considered in the same class with organism, for example, Staph aureus lah. You should never be considered as contaminant. Therefore, anytime you got Candidemia, patient has to be, meaning that it's from a sterile site, from the blood, so it has to be considered as infection and started on prompt treatment. So basically, just to answer that, Candidemia shouldn't be considered as a contaminant.
So there's another question from Dr. Leslie. On the bigger volume of blood samples or blood cultures to be taken, what is your take on this and how big the volume should be? I think this question is probably more appropriate for microbiologists, but yes, Dr. Nadia?
I think we would suggest up to 10 mils. 10 mils. That's the volume for your blood culture bottle.
Yeah, I think this probably directed to the usual our aerobics culture bottles rather than the mycotic or fungal culture bottle. Our standard usually is about 8 to 10 mils for the aerobic culture bottles. Is that right, Dr. Leslie? Okay, while waiting for Dr. Leslie or any of the microbiologists that would like to chip in our discussions here, we move on to another questions. What is your recommendation for Candida endocarditis? I suppose this is in terms of a treatment. What will be the choice of antifungal agents here?
If it's endocarditis, Candida endocarditis, first what I would suggest for referral to our cardiothoracic colleague. In terms of antifungal, I think they would need Echinocandin and also M4B.
Yeah, exactly as what Dr. Nadia mentions. Treatment for Candida endocarditis is considered as a very severe Candida infections. In that regards, we always have to choose antifungals that it has got fungi cytal activities rather than fungi static. So fluconazole is fungistatic. So no choice in these situations, in the severely ill or patients that with Candida endocarditis, we have to opt for echinocandins or amphotericin B only. Sometimes we even consider to add on another agent that is our suicidic, that's our flucytosins. then of course we need the surgical interventions to remove the source or source control. Are there any more questions? We have another 4 minutes. If there is no more questions, I'll just would like to wrap up our sessions today. So today we discussed about Candidemia and a little bit about invasive Candidiasis. So it's very important to acquiring Candida infections. There are many scoring systems, but unfortunately, scoring systems are good with a negative predictive value, but they are poor in the PPV. Therefore, Dr. Nadia has already mentioned the most important risk factor are those risk factors that relevance that pointing out the when there's a breach of the barrier, namely the using of TPN because of a long intravenous catheter, and also the perforations of GI tract or anastomotic leak. Okay, so in terms of diagnosis, we have various diagnoses. Blood culture is still the gold standard, but we have various biomarkers that are available in the market. So if you can get hold of it, that will be great because they have a more faster turnaround time. And in terms of treatment, we have various antifungal agents that are available, namely the azole group, Echinocandin, and Amphotericin B. So which antifungal agents to choose depends on the severity of the illness, and also we also had to go back to our antibiograms. With that, I would like to conclude our sessions today. Thank you for joining us today, and hope that you have a lovely afternoon. And for those states that have a 3 days holiday, enjoy some holiday. Organizing committee.
Thank you, Dr. Nadia and Dr. Lee, for this wonderful topic. We'll see next week for another new topics. Thank you.